Plagiocephaly. This is David Moss from the University of Arizona in Tucson and Cardin Children's Hospital in Mesa, Arizona. Our subject of this chapter is plagiocephaly, specifically non-synostotic or deformational plagiocephaly. The term plagiocephaly is one of several different terms used to denote head shape and do not specifically denote the etiology of the abnormal head shape. Plagio refers to the word oblique. Brachycephaly is derived from the word short. Scaphocephaly from skiff or boat, and dolichocephaly from long and narrow. Trigonencephaly denotes triangular shape, and cranioscoliosis denotes a windswept deformity of the upper calvarium. External forces can deform the shape of a head. Prenatal intrauterine constraint, infant positional head deformities, intentional cultural cranial molding, sleeping position, and premature baby positioning are all examples of these external forces. Plagiocephaly begins in the perinatal time period, usually noticeable by the first month of life. Recommendations were made and initiated in 1992 recommending that babies should sleep in the supine position to reduce the risk of sudden infant death. The incidence of positional plagiocephaly thereafter increased 600%. Ancient cultures have modified the shape of their infants' heads using head wraps or positional devices to achieve a shape that was preferable to them. Ancient Egyptians and Peruvians used head binding techniques to produce cosmetically pleasing and fashionable elongation of the skull shape as early as 2 to 3000 BC. During the last 40 years, increasing attention has been given to the misshapen head, and particularly those with occipital flattening. It has become clear that the pathogenesis is due to gravitational positional forces. The reported incidence of deformational plagiocephaly has steadily increased over the last 40 years, with a documented sudden jump in frequency associated with the recommendations for supine sleeping. 1 in 60 neonates today show some degree of plagiocephaly. The incidence of deformational positional plagiocephaly is higher in infants with congenital disorders, reported as high as 60%, but decreasing to 32% by adolescents. The incidence of deformational positional plagiocephaly in patients referred to torticollis has been reported as high as 95%. Plagiocephaly begins with a constant deformational pressure from gravitational forces applied to one area of the occipital skull in the prenatal and newborn time period when sutural plasticity is high. This can be demonstrated by the shape changes seen in a balloon filled with water resting on a flat surface. The bottom of the balloon becomes very flat. The top of the balloon flattens to a lesser degree. The sides bulge, but also sag, creating an asymmetric bulge on each side of the balloon. Once the flatness of a skull begins, the infant's head naturally rolls towards the flat spot, pulled by gravity, and it takes significant effort for the infant to hold the head in a neutral position. There is compensatory asymmetry that is seen in the forehead and entire skull base, resulting in shift of the ears, mandible, and orbits. This is often described as a parallelogram effect and is shown in the diagram to the right. When the infant begins to spend more time upright, the progression of asymmetry arrests and begins to correct itself by normal continued head growth. Seldom, however, will the asymmetry completely resolve. Some studies have reported that plagiocephaly is associated with developmental delay. Deformational plagiocephaly has not been shown to be a cause for these delays. Children with pre-existing developmental delay or weakness are likely to remain in one position for extended periods of time, increasing their risk for developing deformational plagiocephaly. The most common method of distinguishing non-synostotic plagiocephaly from synostosis is physical examination. Imaging techniques can be used if the diagnosis is in question. Lambdoid synostosis may result in an asymmetry similar to non-synostotic unilateral occipital plagiocephaly. The incidence of lambdoid synostosis is very low, estimated at 3 per 100,000, compared to other forms of synostosis. Therefore, the vast majority of patients seen with unilateral occipital flattening are asymmetric due to non-synostotic plagiocephaly. Various studies have attempted to quantify the asymmetry using measuring techniques, imaging studies, and computer-assistive devices. We found it efficacious to obtain cross-diagonal measurements to determine cranial vault asymmetry, as shown in the diagrams below. Measurements are taken from the frontozygomatic point to the urion in the long axis of the skull, and then a second measurement in the short axis of the skull, showing the difference between these two as defined as cranial vault asymmetry. We followed 1,000 patients obtaining cranial vault asymmetry measurements. We obtained the measurements in 303 patients that returned between the ages of 3 and 5 years. The measurements are shown on the chart to the right. 166 were treated with repositioning recommendations, and 137 with cranial orthosis. The graph shows that the treatments are quite similar and parallel each other, but most importantly, at 3 to 5 years of age, there is a persistent asymmetry, and therefore the defect is not completely corrected. Most treatments in patients with non-synostotic plagiocephaly were non-operative. These include sleep repositioning, neck stretching exercises to reduce torticollis, physical therapy, external orthotic molding devices, and a variety of other investigational techniques. Due to the plasticity of the infant's skull and sutures, all interventions are likely to have greater impact and success when initiated at a younger age. Repositioning should start as soon as possible and be maintained until satisfactory improvement has been realized. Torticollis is frequently associated with deformational plagiocephaly, either as a primary cause or as a secondary result. Neck stretching exercises performed several times daily reduce the propensity of unilateral head turning, making repositioning more successful. Claren reported the use of various helmets for treatment of plagiocephaly as early as 1979. Many helmet designs have been implemented since then and are commercially available by a variety of vendors. The Congress of Neurologic Surgeons, American Association of Neurologic Surgeons, the Section of Pediatric Neurosurgery, and the American Academy of Pediatrics issued a review and evidence-based guideline on the role of cranial molding orthotic helmet therapy. It appears that the currently accepted management of positional plagiocephaly in infants using conservative therapy, repositioning, and physical therapy for the treatment of mild to moderate deformity in younger infants and reserving helmet therapy for more severe deformity, especially in those infants who have failed to see improvement with conservative measures, can be justified by the data. The impact of plagiocephaly in the infant encompasses social, economic, and developmental factors and is so widespread that in lack of definitive, successful, and complete cure of the disorder with today's treatments, one must conclude that prevention measures instituted early in the infant's life during the first 2 months is pivotal in managing plagiocephaly. Pediatricians need to be able to properly diagnose skull deformities, educate parents on methods to proactively decrease the likelihood of the development of occipital flattening, initiate appropriate management, and make referrals when necessary. Upon discharge to home after delivery, education about plagiocephaly prevention must be coupled with the education for supine sleep positioning that parents receive in caring for their newborn child.